Welcome, everyone. Thank you for joining us today. My name is Dr. Louise Ivers, and I'm the director of the Harvard Global Health Institute and a professor of medicine and professor of global health and social medicine at Harvard. I'm delighted to welcome you to HCHI's Coffee Sessions. This is our virtual series that brings together voices from across the global health landscape working to advance global health equity. In recognition of the growing complexities around the US's engagement in global health, today we're going to focus on global health as a moral imperative and the United States' role in advancing equity and partnership. A few notes: the session is being recorded through Zoom, and the recording will be made available on the HDHI website and our YouTube page in the coming days. We're planning to have time at the end of the presentation and the discussion to answer your questions. So if you have a question, you can submit it to us and to the participants in the session through the Q&A feature on the bottom of your screen. And we'll do our best to get to your questions towards the latter part of this event. So with that, please allow me to introduce our really phenomenal, amazing speakers today. I'm absolutely thrilled to have them both here with us. Dr. Wesler Lambert is a physician and the executive director of Zami La Santé, which is also known as Partners in Health in Haiti. With more than 20 years of experience in global health, Dr. Lambert has dedicated his career to improving healthcare in resource-limited settings. Since joining Zami La Santé in Haiti in 2002, he has advanced initiatives that are focused on HIV, tuberculosis, maternal health, primary care, and medical education. He has forged strong partnerships with government agencies and international stakeholders to strengthen health systems in Haiti. Dr. Lambert has held a variety of senior leadership roles, including Deputy Executive Director and Senior Director for Education, Research, and Strategic Information. And in these positions, he's guided policy reform, managed organizational restructuring, managed crisis response, and established the organization's project management office. In addition to his leadership, Dr. Lambert is a published co-author on health systems and infectious diseases and has received several honors for his work, including the Unsung Heroes of Compassion Award and the Boston University School of Public Health Merit Award. I've enjoyed and learned so much from working with Dr. Lambert over the last 20 years, and I'm delighted he's here with us. Welcome. We also have with us an amazing humanitarian and physician, Dr. Craig Spencer. He is an emergency medicine physician and associate professor of the practice at Brown University School of Public Health. With nearly 2 decades of experience in global health and humanitarian response, he has worked on critical public health issues across Africa, Southeast Asia, and beyond, including leading epidemiological responses during the West African Ebola outbreak and providing clinical care on board a search and rescue vessel in the Mediterranean. Dr. Spencer's work focuses on the historical foundations of public health, humanitarian response, and pandemic preparedness. He frequently shares his insights on public health and policy through writing, with pieces that have featured in the New England Journal of Medicine, the New York Times, the Atlantic, the Washington Post, Politico, Los Angeles Times, Think Global Health, USA Today, and more. He is a life member of the Council on Foreign Relations and serves on the board of advisors for Doctors Without Borders, USA. So Drs. Spencer and Lambert, it's an absolute honor to have you here with us today. I can't imagine 2 more phenomenal people to get the conversation going with us today about the moral imperative for global health. So I'm going to turn to each of you. I'm going to start with you, Dr. Lambert, to ask the same question. What does this concept mean to you? What does it mean? What does a moral imperative for advancing equity and partnership in global health mean to you?
Good morning, everyone. Thanks so much, Dr. Ivers. It's been a while. We have not seen each other. I'm so grateful to your advice, friendship, and I learn a lot from you as well. Thanks once again to be part of this great panel with Dr. Spencer. A moral imperative in global health for me Louise, means remembering that behind every policy or funding decision, there are people, there are human beings, there are patients whose life depends on whether they can access care with dignity. Advancing equity is not about geography, generosity, it's about justice. No one's chance of survival should depend on whether they are born in Haiti or in the US, or the strength of their country's budget. Partnership in this sense means working side by side, and too often low-income countries are treated as passive recipients of aid, passive recipients of global assistance. A true moral partnership requires listening to local voices, building on their strengths, and sharing responsibility. In Haiti, I see this every day. When the US support aligns with the Ministry of Health activities and with community networks, we don't just deliver services, we strengthen the system that will outlast any single project. This is what equity and partnership look like for us in practice. So when I say it's a moral imperative, I mean it is not optional. It's about doing what is right, even when it is costly or politically difficult, because health is a human right and solidarity must guide our collective choices and actions. Thank you.
Wow. Okay. Powerful words to get us started. Okay, Dr. Spencer, Craig, if I
Yeah,
may.
absolutely. Please. Thanks again, Dr. Ivers, for having me and hosting this. And Dr. Lambert, we haven't worked together, but it's a pleasure to hear and learn from you and everything that you've done. I think that's a perfect start and a perfect framing. When I think of the moral imperative, I think about the fact that all of us that do global health, I imagine most of the folks that are listening to this call today, part of that just comes natural because when you're standing somewhere else in front of someone else, you see them as a human, you see them as part of a family, you see them in a different way than a number on a spreadsheet. And I think many of us have had that experience. I certainly have. So it makes it easier and more compelling. But if you look at what's happened over the past 8 or 9 months, and we've seen the destruction, particularly of the US presence in global health, what did we as a community largely rely on to try to defend the work that we were doing? We relied on the national security imperative because we thought that's what would resonate with people like many of those in my family who don't necessarily always see the moral imperative as a national security imperative. And I did the same. I wrote a piece in the Atlantic in March that was titled "The Diseases Are Coming," as in a way to try to frame our investments abroad as a way to keep us safe at home. And I think that was the right thing to do. But we all of us working in global health had a moral framing, but we did not rely on that initially. And I'm ashamed to say that a piece that I wrote just a few months ago in the New York Times about the role of empathy in global health was not necessarily my idea. I didn't pitch it to them, they pitched it to me. And I said, I don't know how this is going to land. Like, is there an argument for a moral imperative for global health right now? And the responses to that piece just like filled my heart because I got messages from people all over the world, Buddhists and pastors in red states in the US and global health folks, and just a whole swath of society that said, thanks for this message. We needed to hear this message right now. And for me, it was a reminder that despite what we're hearing, despite the rhetoric, despite the funding cuts, the overwhelming majority of people in the United States support sending money, sending food, sending medicines to other places in the world to continue our global health activities. And so for me, it was almost a forced and delayed reminder of how resonant the moral imperative is and how we need to continue to double down on that importance to continue to do the work, this life-saving work and really important work that we've been doing for a long time around the world.
Well, it's so interesting. Thanks for sharing that. Even that piece that you wrote in the New York Times was not initially what you thought of writing, or maybe wondered if there was a place for that, because I think we have been talking on our side at the Global Health Institute, as we've been having a number of sessions over this year, asking speakers, is there can we still make this case? But I think it's maybe a natural position to try to think about, well, what case can we make? If we have a portfolio of reasons why this work is meaningful, what's going to resonate with those who are in power and have the resources and what's not? And I think it's really heartwarming to hear that you had such an overwhelming response to the moral case, which can sometimes feel difficult to make, even though at the same time it feels very natural. I mean, in your article, which, if our audience members have not read, we certainly will link in our notes on our recording of this session because it was so powerful. You wrote that America's global health commitment is, quote, the moral foundation of a meaningful life. And although we'd planned this session, some time ago, just last week, the new America First Global Health Strategy was written. And it's interesting because there's a lot of really correct things in there. But the fact that it's even named America First Global Health Strategy, um, even if many of the tactical and operational objectives are appropriate and correct, and many would agree with them, how do both of you think of this? How do you think of examples that this obligation isn't the collateral damage, as you wrote, of the priorities? Could you reflect a little bit, each of you, on this? Maybe I'll start. I'll keep going with you, Craig, and then we can go back to Lambert.
Yeah, absolutely. And I was reading the new America First Global Health Strategy, and you're right, there's a lot of things in there that I actually do agree with. And I don't know why I found myself so surprised at that, but particularly the role of NGOs and how NGOs can and should do a better job of more durably integrating into health systems. And the continued insistence on supporting disease surveillance. I love the fact that 100% of the frontline commodity purchases and support to frontline health workers is included in there. That's great, but I think that the framing is so narrow. It starts with that America First, and it also talks about how disease outbreaks need to be managed so they don't come to American shores, as opposed to just managing them so that they don't get much bigger in place. And we see that as part of the approach of the US pulling back money from Gavi, and how that is undoubtedly going to lead to more outbreaks of vaccine preventable illnesses. It's only a period of time before those things coalesce and ultimately impact us here. But when we talk about, and when I think about the collateral damage, I think about our own moral collateral damage and what that looks like. Because the story that I shared in the New York Times piece was that I was working in Guinea as a healthcare provider, providing care during the Ebola outbreak. I continued to take care of people even when I knew that they weren't going to survive. And part of that was because I wanted to make sure that when they died, they had they weren't covered in their own vomit. They weren't, they were able to die with dignity. And when I was hospitalized and treated for Ebola, I was given the same care, the same kind of dignitable respect that I think we all deserve. And for me, it came obviously too painfully and too profoundly full circle, but I was able to see that the inputs that we put into this come back to us. So whether it is our investments in disease surveillance or the money that we put in to develop Ebola treatments, using the experience in the communities in DR Congo or in West Africa, all has a benefit to us, not just from a national security perspective, but from a moral perspective and ethical perspective as well.
Thank you. And I'll definitely come back to some of those points. And I want to maybe ask you, Wesler, still staying on the America First document and strategy, one of the comments in there is about how, US foreign aid has resulted in a dependency. And the requirement in the future of governments to share costs and other things. And many of this transition of responsibility, of course, is again things that many of us in this sector would have been working on and support. But can you speak a little bit, especially because, and we've worked together in Haiti for a long time, like the situation is incredibly challenging. Would you speak a little bit to that, the dependency comments, and how could we move forward with that? Like, what are the risks? What has happened in Haiti over the last 8 or 9 months in your organization with the rapid withdrawal of certain funds? And what are the challenges for countries that have multifactorial, complex issues going on?
Yeah, thanks, Louise. It was so puzzling for me reading. I read the America First strategy, I think a day ago. It's clear that it argues that the U.S. Health aid fostered dependency, as it's clearly stated. Since as they say, recipients' government only covers 30 or 40% of their costs. But these figures hides major differences across contexts. As we all, get it. You cannot apply a one-size-fits-all approach. Country readiness varies depend on government engagement, as we all know, socioeconomic stability, levels of violence, like in our case in Haiti, and the size and needs of their populations. In Haiti, decades of underfinancing, political instability, and today's security and economic crisis mean the government is not all prepared to take on a larger share of healthcare costs. Over the last few months, almost 80% of the western region of Haiti around the capital city, in terms of healthcare facility, they have all been destroyed. And our main hospital, the largest, teaching hospital in Haiti, we have been we had to close it because of organ violence. You can imagine, the impact that such strategy will have on Haiti. And the country, Haiti continued to lose trained staff to brain drain, forcing a partner like Zamila Santé and other to focus heavily on capacity strengthening. So despite progress, alignment, procurement, data, and staffing with the Ministry of Health, repeated setback, particularly in security, requires NGOs like us to keep carrying a disproportionate load. If donor is withdrawn too quickly, in our case, the risks are immediate: treatment interruptions, medicine stockouts, and a reversal of hard-won gains against HIV and TB and other diseases. Like you remember when you all these great achievements, we did together in Haiti. The recent 40% cut in CDC paid for instance, illustrate this danger, threatening continuity of care for thousands of patients on antiretroviral and at-risk population. It also raised the likelihood of new HIV and TB epidemics. So for a country like Haiti, expecting the government to suddenly cover more than 30 or 40% of program costs is unrealistic in practice. It will shift the burden to partners, to NGOs. We are the strongest Ministry of Health partner, but dependency is not inevitable, as Greg was stating. But transition must be gradual, realistic, and adapt to country conditions.
Can I just add on to that, Dr. Lambert? 'Cause I think that's exactly the point, right? There was so much in this report, this new America First strategy to global health, that a lot of us agree with. In fact, many of us have probably written or talked about some of these things in the past. What was immoral about it was that overnight, so many of these programs were just ripped away, and there was no planning for what would come next. And so some places have put things together. It's unclear, where HIV treatment was able to be transitioned. I'm hearing about people from friends of mine working in places all over the world where there's been inconsistency in people's ability to continue their treatments or antiretrovirals, for example. So even if you don't believe in the strong moral imperative of the US's role in global health, I hope we all agree that what we did and how we did it truly overnight was immoral, and that all of us want to shift away from a dependency. Nobody here, either in the US or in Haiti or in Burundi, where I've worked a lot, wants to be dependent on others. But you can't just rip a Band-Aid off and hope that that wound has healed in the span of a few moments. We need to think about what that transition looks like. So there's some promise here in this document, but so much has already been destroyed that I don't know that we can start some of those things back up again in a way that is as impactful as the document recognizes. It talks about the fact that PEPFAR was brilliant. And not only did it save millions and millions of lives, but it helped with political stability and economic stability. So the moral imperative has economic imperative, has political imperatives, has other things built into it. And we unfortunately got rid of one leg of that stool, and I don't see how we get it to stand back up so quickly.
Yeah, thanks. And I often think a little bit about, the audiences for various aspects of the type of work that we and so many in our audience today are engaged in. And it strikes me that the concept of dependency, or using the word dependency, could be a bit of a lazy way of thinking about it. It's ahistoric, and you know, like we could talk, maybe we can talk for a few minutes about both in Haiti, the notion that, oh, now, the health system is dependent on the United States is completely neglecting to reflect on the United States' role in the current economic status of Haiti, or the fact that, the guns being used by gangs in Haiti are coming from the US, or Craig, the Ebola epidemic in West Africa, which you've spoken to as being ultimately having had Ebola, like what the historical context has been there to make health systems fragile. And that doesn't mean that, we're not, I mean, we want to create systems that will foster, Haitian agency and leadership and African leadership and other places, but it's reductionist, I think, to call it dependency, and yet then that will resonate with, the general American taxpayer, I think, who's not in the nuance, because of course it doesn't make sense to foster dependency. So how do you think of kind of unpacking that, or thinking about that? Will you share, or even communicating that? Can you reflect a little?
I absolutely, look, I completely agree. I think we can talk about the long history of coloniality and the impact that it's had, the extractive economic and health impact. Some people are unfortunately not persuaded by that. But when we think about dependency, let's flip it around and to think about how we as Americans are often so dependent on people around the world, our own health and security. And so go back to many of the earliest vaccines, cholera vaccines, many of the earliest vaccines made in the early 20th century. They were trialed not in the United States, but they were trialed on bodies in Africa and Southeast Asia. We have those scientific advancements today because of that. When you think about lenacapavir, which, this groundbreaking HIV medication, unbelievable. I'm glad that the U.S. is continuing its previous commitment. I'm glad that the Clinton Global Initiative and others are finding ways to roll out this truly groundbreaking treatment. I'm sorry, this preventative for HIV. But look at where this was trialed. Again, this was trialed in sub-Saharan Africa. This was trialed in South America. This was trialed in a lot of places where we are going to benefit here. People in this country are going to benefit. And the last thing I'll say is that right now in our strategic national stockpile in the United States, we have treatments for Ebola. This is amazing. I wish we had these a decade ago. We have vaccines for Ebola. The US put the money in, sure, but when it comes to the treatments, what got us so far was that one of these treatments was created literally from the blood of an Ebola survivor in Kikwit nearly 3 decades ago. These trials were done in Congo with Congolese communities, with a health system that the US helped support to do these trials. And because of that, we now in our stockpile have these medications that if any of us were to get Ebola, our likelihood of dying would be decreased because of the work that was done, our dependency on the ability to do this work in other places. And despite all that, and despite, the attempt to make lenacapavir more available for many people in the world, there are still a lot of people that were part of the trial group that will not be included. And right now in Congo, there's another Ebola outbreak. And there's still a lack of clarity on how many doses or how quickly we can get the doses of a treatment that was created in Congo from the blood of a Congolese person, trialed in Congo, back into Congo for their ability to treat this. So I think that we have our own dependency on what we rely on the rest of the world to do for treatments, regardless of our own extractive history, which I think is big. We need to recognize our own dependency and what we lose should we brush that all aside and think we can go it alone. We can't. History has shown this time and time again.
Thanks.
Thanks, Chris. I found this statement about dependency a bit hypocrite. For a country like the US in its relationship with Haiti, we know, in history clearly showed us how influential the United States and other countries, have on Haiti. Which country, which population would like to be dependent on others? Everybody wants to have their freedom to, to thrive, to take care of their lives. But when you look at the history of assistance, international assistance and aid that a country like the US has provided to Haiti, there's little peace for system strengthening to put system in place in a way that the country will will start working on its own and becoming independent. So I find it a bit, it's striking how, today the US is talking about a dependency. But if we can work, I believe many countries would like to work in partnership with the US and strengthen the system in a way that they don't have to rely on the US for everything, and particularly for the healthcare sector.
Yeah, thanks. I'll go back to a quote from your article in the New York Times, which I know it's not the only article, that you've written. You're such a strong communicator, but um, you spoke to empathy and you gave your own personal experience as the recipient of caregiving and of providing care. And you spoke about the fact that America's strength isn't from isolation or indifference, but from an instinct to care beyond our borders. And I don't know, we're all three physicians, and something about staying close to the patient and remembering the patient. And in your case, you're sharing with the world your experience as a patient seems really maybe relevant, because it can be easy to begin to be distant from that. And I think you talked about spreadsheets and Wesler, you talked about there's a patient, there's a person behind each of this. Can you speak to how this frontline experience, I'll call it, informs how you think global health leadership has to adapt today as the policies and structures shift?
Would you like me to start, or Dr.
Yeah,
Lambert?
sure.
Sure. I think it's a really important question. I've now transitioned to a position at Brown where I'm a full-time public health person, which I love and is great and gives me time to write and think about these things and teach. But I continue to work clinically every week. And that's so important for me. Um, it is so different, but the ability to kind of put hands on a patient or just to speak with someone individually is so different than the rest of the work that I do and remains so incredibly important. And in that piece I wrote about empathy for the New York Times, I started the story talking about what it was like working in a Ebola treatment center, what it was like taking care of people who were in the last minutes of their life. And for myself, it wasn't even a consideration of what to do. You jump in, you help. And I knew that there was a risk, of course. All of us knew that there was a risk. But it seemed like really the only action that we could do was to try to help. And I had people reach out to me to say, I don't think that I could have done that. I had a lot of friends that said, I don't think that I could show up in that way. And that's okay. We don't need everybody to kind of have the same risk calculus that I and others have. But we need some of us to, and we need some of us to understand that our ability to show up remains so incredibly important. It remains important not just for stopping outbreaks, it remains important for people to feel like they're seen. It remains important for solidarity. And selfishly, this is the argument I've been making, is that when you show up, people will show up for you. I think we all know this with high school and with friends. When you show up, people show up for you. And I don't think that any of the folks that took care of me in the hospital when I had Ebola and when I was at my sickest, I'm sure that they had concerns. I'm sure their family worried, but they did it. And I know that they did it because they were committed to caring. And I think that for us to continue to be able to do this work and to do this work well, we need to show up. We need the US showing up in a way that is working as a partner, that is working in solidarity, that not only advances the interests of the US from a national security perspective, but it continues to work in the moral imperative and the requirement that we have to be on the front lines. I think they work together. I don't think it's an either or. When we put one with the other, I think they both get that much stronger.
Thanks. Wesler?
Yeah, thanks, Louis. And Craig, you just remind me the level of solidarity and commitment that the team in Haiti, and particularly those working at the Teaching Mibale Hospital, have shown over the last few months. I just, share like that story with you. You know how much damage the Biden initiative has done in Haiti, pushing hundreds of Haitian to leave Haiti, but mostly on the health sector, doctors and nurses, clinicians who have left Haiti. And you also heard about this level of threats and insecurity that this team has to experience every day. So many of them have the choice to leave the country, and most of them decide to stay. Yes, we had to close the hospital because of insecurity and threats for the patient and staff, but they're all around in the network. Dr. Arias know very well, the how the network is set. So they are happy. They were happy to be relocated to other hospitals in Saint Mark, in Haitian, all in the central Haiti and the Artibonite region. This is real uh, um, um, uh, expression of solidarity and engagement. Many of my friends, I share my time between Haiti and Canada, where my family lives, and sometimes they're asking me why you're going there. Even like last week, coming this, I was in Cap-Haïtien, north of the country, this weekend to attend the graduation of 27 specialists, trained by our system, by the Zamila Santé Partners medical education program. And then I went to Port-au-Prince to meet staff, and people say, "Oh, you crazy? Why you go there? You have people who can do the work. You can still work remotely." But this is not what the real sense, the real expression of solidarity and engagement should be. So you have to be there side by side with these people, even with patient, just to see you. Oh, this big sharp rock, Louise know what I'm talking about. Like you at this level of, responsibility in the organization. Why you come down there? But these are real examples of what like clinicians, practitioners, like even policymakers. These are the type of example they should follow. So people can see us, differently, and that can make significant difference in everybody's life.
So, Wesler, you were telling us earlier you're working now, like this week, on work that's following up from a humanitarian disaster from a few years ago in Haiti, and an earthquake from recent years. And you were part of the response back in 2010 to the massive earthquake in Haiti. And when I think about, I wanted to ask you a bit if you can share, your experience in that type of humanitarian disaster. The policy, it seems, from the US federal government is really pretty focused right now on infectious diseases. And that is going to resonate with the notion of global health security, protecting Americans from what might come to American borders. But the 2010 earthquake in Haiti killed hundreds of thousands of people. I was there, you were there. We had the personal experience of that. But will you speak a little bit to that? What's going to happen in terms of those types of emergencies, health crises? They also contribute to this, breakdown, rebuilding that is part of what results in places sometimes not being able to get ahead of the insults to their health systems. Can you share a bit, Wesler, about your experience on that?
Thank you so much, Louise. And this is an an opportunity for me to thank you publicly in this for the in front of this audience for the wonderful contribution and work you have done after the earthquake. You are one of my best partner in addressing the needs of the hundreds of thousands that were evacuated in IDP camps. I'd like to underline one of the biggest challenge in working on disaster response, which is the stop and go nature of supporting in general. And when a crisis or funding and attention often arrive quickly, but recovery and prevention, as we all know, require long-term commitments. And those resources are much harder to sustain. Everybody, when after all these earthquakes, we receive massive support from all over the world. But yes, that sickle leaves health facility we built, but not maintained. You remember like 2 years after the 2010 earthquake, most of the partners, they left. Yes, they have help in the immediate, period of the crisis, but then we see today what's happening. Fortunately, Mibali is a good example of a partner, of partners in health and some other partners who are thinking about this long term. And today, and remember, and we put together the medical education program, which train clinicians who are at the front line when the 2021 earthquake hit the southern region of Haiti. So, and another challenge also in my experience, which is the work infrastructure, and political instability, that make it hard to align external aid with government systems. We have to put that, on the table as well. And too often, parallel programs are created that save lives in the moment, but they don't strengthen national capacity. That's been said, there are real opportunities. And I think as we're talking about the US today, the US has an unmatched technical expertise, supply chain, capacity, and global reach, as we all know. But when that is paired with local knowledge and community-based networks, we can respond faster in ways that is more equitable. For example, partnership that pre-position supplies, for instance, strengthen community health workers, and invest in resilient facilities can turn emergency response into long-term preparedness. I think these are the lessons that we learned over the last 10, 15 years with two major earthquakes that have hit the country. But the key is to move from short-term reaction to durable partnership. In Haiti's fragile environment, disaster response and crisis prevention cannot be treated as separate. The opportunity is to align the US supports, for instance, with efforts that both save lives now and build systems that we need to withstand the next emergency.
Thank you. We're getting a number of questions coming in from our audience, so I'm going to kind of include some of those questions as we move into the last 20 minutes or so of the conversation. One thing is that I'd like to maybe probe into the comments. Wesler, at the beginning, you said that true moral partnership is not optional. And Craig, you spoke about the rapid, defunding of global health and as immoral. How would you react to the concept, if I was to put it there as a hypothesis for discussion, that the US actions at the moment are immoral, that it's, because one of our audience members who's coming from India says that the framing of this webinar is profoundly problematic. And how could we speak of global health as a moral imperative when the American strategy is openly calling for the opposite? And in the cover letter of the America First strategy, Marco Rubio's stating that the efforts are directly to benefit the American people and directly our national interest. Although, US aid has always had the purpose of advancing it was written in the US aid's, website, like, our purpose is to advance the mission of the American people. But so the question from that audience member is, should we be taking a much more profoundly clear stance on this, or how do we use this moral framework to make our argument? Are we not being strong enough even in this conversation?
I think that's a great point and a great question. And I also want to point out that I kind of agree. Look, it's easy for us to sit in September of 2025, and I hear a lot of people, although less so, in February and March, but I hear a lot of people say, "Oh man, if only we could go back to January, right? We'd have PEPFAR and we'd have US engagement and things would be okay." The reality is that there has been a problematic moral framing of how the US has always done global health work. I teach a class called Lessons Unlearned in Humanitarian Response. I talk about operational amnesia and how we continue to make the same mistakes in humanitarian crises, responding over and over again. And USAID is part of that. US funding in support of certain NGOs and the incentive to continue to get bigger and expand their mandates is part of that. The US role in things like Biafra and why we engage, the US's role very reluctantly in the response to the Ethiopian famine in 1983, 1984. The US role in every single humanitarian crisis, including in Haiti, has been questioned for not only how it set up the conditions for that event to happen, but for the questions on how it responded. The US and Haiti in 2010, 2011, so much criticism about how much money was committed but never left the Beltway. So I want to be very clear. I don't think that there was a golden age of global health and US engagement. I think what we're seeing now is a degradation of some of the best parts of what we had. But this should also, for us working in global health, make us realize that there is opportunity in entropy. That yes, the way that this is framed now, where we can just shut out the rest of the world, put up, a big wall around our country, try to manage some of those outbreaks abroad, and then hope nothing comes here, is problematic because it just is not feasible and won't work. But what we need to be thinking about now is not just what isn't realistic and really isn't good about this framing and about this plan, but what wasn't good about the plans that we had in place before, and how do we constructively create a global health framework on behalf of the United States that not only prioritizes the moral response, the solidarity response, but the national security response. During the pandemic, I got so angry at the US and I said, we need to do more to distribute vaccines equitably around the world. And I spoke to a bunch of people at the White House that said, this is wonderful, great moral framing. The reality is our responsibility is first and foremost to the American people. And that's true when it comes to US global health strategy. We can delude ourselves to think otherwise, but that is what we're going to be doing. Now, we need to make it such that those requirements and that those considerations themselves have a moral component to them, not just an Orientalism of where epidemics come from. That is, I think, what we need to do as a global health community, recognize that the US is always going to, not just over the past 9 months, but over the past 90 years, have the US at the center of its global health commitments, but we need to think about how we center the things that also matter, the moral framing, the ethical framing. That I think we can do a better job going forward.
Lambert?
Yeah, yes, Louise, just quickly, I think we still have a major, we all, policymakers, clinicians, students and advocates, we still have a role in this, in pushing the US to take more, to take on their moral role toward global health. We all, as I said, like clinicians, for instance, we can use our professional platform for global solidarity and equity. Even students, like advocates, challenge deficit-only narrative of countries' experience, elevate the stories of dignity, resilience, and courage alongside need. Policymakers, even those who can still influence the U.S. government, they can still play their role, especially in this fragile context. They can still, there are ways to prioritize, programs like HIV, TB, maternal health, and workforce training. But it's still, I don't see, it's not a lost case. There's still a lot that can be done to reverse what we see happening today.
Thanks. Dr. Lambert, I'm going to stick with you a little bit because working in Haiti and learning from Haitian leaders like you and others, like I was always infused with the concept that this work is about justice, that and the concept of social medicine as part of, the education of yeah, like European physicians like me or US physicians or Haitian physicians was kind of infused, and leaders there used to call it being cooked in the sauce of social justice. Will you speak maybe a little bit to that, especially because you've had so many roles there in Zami La Santé, but including in medical education, and how do we continue? I suppose one thing that I'm really thinking about, especially this morning as we speak, is how to not reduce the concept of this moral argument and to continue it. Obviously, it's not the only argument or the only case, but it has to be infused and integrated into the very practical and tactical things we do. So, how do you think of that, Dr. Lambert, especially as you continue this amazing work in Haiti in the crisis, the multifold crisis? Is it part of your education of the next generation of leaders? How do you infuse that into the partnerships you have? Oh, you're muted. It only happened once. We've done quite well, actually.
No. It's I was on mute. Thanks for asking, and I know how much you're cooking this sauce as well, the social medicine, and how much a difference is making and he has made in people's life, people, the population that we have served over the last decades. And I can tell you guys, I've been trained in the School of Medicine in Port-au-Prince and start being with a different approach to patient care. And I remember well, and I will always thank Paul Former to have changed our mind, how we see patient, and we can see today how much transformation that has made on physician clinicians. And I was telling you earlier that I was last Saturday in the graduation, attending the graduation of the specialists. But with the conversation I have with them, it just it creates hopes in me about how I see them approaching their and their patient. And all these were made by how much how much social medicine has transformed the way they see patient. And I think it should be called to any global health practitioner today. And social medicine should be thought to any global health programs. And I hope it is the case that make us see things, that make us approach the patient, that make us see the systems, that make us see, even like global health in general, how we approach all this to make sure we see, the patient in front of us as one of us. And then that's a way we can change. People are always talking about like changing the world. That's our way to change the world as practitioners, as clinicians, as global health activists. So yeah, they've has been cooking this sauce, make me feel like today I have to be here in the southern region of Haiti. It's raining. I have to go out and meet a Minister of Health leaders. So yeah.
I'd love to speak a little bit about partnerships. And so, the role of global health partnerships, again, I like how you said, it's not like there was a golden era of global health, and for many of us in it who would like to try to reshape it even before these drastic changes of 2025, one issue that often comes up is about partnerships and how many global health partnerships have really benefited the global north. especially in academic institutions where research is a priority output and many people get promoted in global north universities for their research. It can be extractive, and other things too. And you touched on some of these, like we benefited from vaccines and such biomedical interventions. Could you each reflect a little, because you've both worked between the NGO kind of humanitarian response sector and also the university academic sector? How should we be kind of anchoring or thinking about moral partnership that embraces many of the things we would have talked about pre-2025 about equity and power dynamics, and how we might have to work together into the future? Because what I'll also mention is the document, the America First Global Health Strategy, emphasizes a preference for bilateral relationships with the US, although multilateral partnerships in some circumstance, which again to me is less where I would favor going, because I favor multisectoral, multilateral partnerships. But could you reflect a little bit on what, I guess, the concept of moral leadership means in terms of partnerships going forward?
I'm happy just to quickly start and say
Right.
that this is a place where we can do better. And by that, I mean the global health community, primarily in the global north. If you think about the fact that most funding for global health goes to global north institutions, even when the issue is to be studied in the global south by global south researchers, they only get like 10 to 15% of the funding. So obviously there are economic incentives and things that we need to think about where we seed ground. Also, if you look at global health leadership, the overwhelming majority of leadership positions, particularly on boards, is located in the global north. And the representation from people from low and middle income countries on global health boards is like less than 2%. It's like, infinitesimally small. It's the same for women. And so I think it's easy for us to point fingers, and I think there's a whole host of fingers that we can point here. Bilateral relations, great. I think it's, the trade, not aid. A lot of countries have been saying the same thing, even if they didn't want it in the same way. I think losing the multilateral aspect of this, the multilateralism, particularly around things like responding to Ebola outbreaks, is going to be a missed opportunity, and something that unfortunately we've learned in the past is not a good way to move forward. But maybe we'll make those mistakes again. But I do think that we need to recognize that it's not just pointing fingers out, but we need to point fingers in and think about how we can do better, whether it's funding, whether it's leadership, how we convert our own talk to action. Over a decade ago, there was the World Humanitarian Summit talking about how we were going to focus on localization and how we were going to support people on the ground better. And I think every assessment of how we've done in the past decade will say that it's been painfully slow, inadequate, and not up to the call that we all wanted and all hoped for a decade ago.
Thanks, Luis. It's just remember, I'm part of that coalitions called Partners in Health. We call ourselves Partners in Health. If there is one word today that is so timely, that can serve as a response to what that can serve as a response to the U.S. position today, is partnership, please. Definitely it's about, and we all are witnessing huge gap that the U.S. position will leave in the global health today in the world. So this is the time for real partnership to be created and to be put in place in strengthening, country systems, so they don't have to rely to the north, as you said, Craig. So collaboration with regional organizations, for instance, in our instance, like the diaspora, there's a real opportunity in Haiti, for instance, to bring the diaspora as a major partner to address. I'm talking about the Haitian diaspora. It's about the diaspora of many other countries. We know how much economic influence they have on their countries. Faith-based organization, if we can work together, they can sustain services that the US today engagement is shifting away. So even private sector in those low-income countries, they have their role if being managed with accountability, they can play a role in logistics, digital tools, financing, all this stuff. So there's a real opportunity to make, you know, the partnership, what we have been calling partnership, a reality in those settings, those countries. That can be a major response to address the gaps and issues that the US will leave with their American first strategy.
Yeah, thank you. I mean, we have just a couple of minutes left. So what I wanted to do was maybe give you each, a minute to share anything that you had kind of wanted to say and we didn't get to touch on, or closing reflections. It feels hard to kind of close the reflections, so it's okay. There's a lot. So maybe I'm gonna start with you, Craig, and then we'll give the last word to you, Wesler. So over to you.
Great, thank you. And thanks again for doing this. And Dr. Lambert, it was so great to hear from you, and your voice is so important. So thank you. I'll be very short. Look, empathy and equity have become seemingly dirty words over the last, 8 or 9 months. I think it's easy for us to think about caving, to think about workarounds, to try to continue to do the work while ceding the moral ground. But I actually think now is the most important time for us to double down on these commitments. I think it's the most important time for us to continue to have these conversations, to talk about empathy, to talk about equity, to make sure that we continue to frame what they mean and why they're so important. And I say that because if we don't double down, we will not only lose, the well-being and the impact on the well-being of others, but I think we'll lose a big part of who we are. And so I just want to end with that and say, don't feel bad if you still feel the moral imperative. Don't feel bad if empathy is a really big part of why you continue to do this work. It will remain so for me, and I think we need to continue to remain vocal about how important that is. Thank you.
Thank you. You're still on mute, Dr. Lambert.
No, my connection is still very good. Thank you so much, Reese. Thank Greg. It was, it was such a pleasure to be with all of you today. But if I have like some closing, statement, it will be about solidarity with patients and communities. See, healthcare as solidarity instead of charity. Political cycle will always shift. But what we must endure is the principle that people's access to care should not depend on the politics of the moment. In short, if solidarity and respect for health as a human right remain at the center, then regardless of political changes, our collective response to global health challenges will be stronger, more just, and more human. Thank you so much.
Thank you both so much. This has been an incredible conversation. I really appreciate you for taking the time. I think our audience really appreciates you. Thanks to our audience for joining us from all over the world. We've appreciated your questions. I think we appreciate, as a community, challenging each other to go further with what we're saying, to unpack things more. And I, for one, feel very inspired and assured that we have a community who really want to put the focus and keep the focus on the moral imperative and health as a human right and the justice aspect, and that we should find each other and keep each other strong as we also adapt to some of the things that may not be within our control. So thanks to everybody so much for today. Appreciate you both very much. Have a great rest of the day, everyone.
Thank you.
Thank you very much.